Dr. Nagalaksmi. She will be speaking against, or she's speaking for general anesthesia for Pcnl. She's from Tanjavur Medical College, professor there. She has 8 publications. She has been actively involved in ISA, and she has areas of interest are airway management, pediatric anesthesia, and regional anesthesia.
Okay, am I audible? It's nice to see a full house after a lunch session, and I thank my previous presenter for a wonderful presentation. Now, without any disrespect to both the anesthesia techniques, I would like you to go through the cons of regional anesthesia. So the distinguished audience can tell how many of you prefer to do PCNL under regional. You can raise your hands. Under GA? Under GA? Yeah, that answers my question. Most of the people would like to do PCNL surgeries under GA for safety and other things. So now let's go through the slides. So now, let me take you through the indications of PCNL. So if the renal calculi is more than 2 centimeters, and if it's a stagon calculus, a lower bone stone, and stones in abnormal and anatomical abnormalities, and calyceal diverticular stones, and refractory upper tract calculi. All these are classified as difficult stones, or they may come for repeated procedures. So these stones might require a longer surgical duration, and the patient will have to be in a position which is unphysiological. So, so these are the indications which are surgically difficult to approach. So, and I'll take you through a few positions, and I would like you audience to tell me if these are physiological positions, and if you will do a regional and with these positions. So now, coming on to the positioning and its anesthetic significance, we do PCNL under 3 positions. First is most preferred, that is a prone position. Here, the disadvantages of this prone positioning or difficulty in airway access. There is a decrease in the cardiac output, and if there is a abdominal pressure, if you are not properly positioning the patient, the abdomen might be compressed and lung complaints might be decreased. And the second best will be the lateral one. Here, the disadvantages are the suboptimal airway access, there is a ventilation perfusion mismatch, and compression of the lower arm, and difficulty in staying in that position for a long period. And if the patient has to undergo a urethrostomy procedure also along with PCNL, then we prefer to put the patient in a supine position. There are various modifications also, I'll come to it later. So in supine positioning, there may be a decrease in FRC and a ventilation perfusion mismatch also. Now I'll show you a few pictures of the positioning. So this is the classic prone positioning, and if you see, the abdomen is has to be free, and it has to be supported. And can anybody think of a patient lying in this position for 2.5 to 3 hours? The patient might complain of pain, discomfort, and it will be a little difficult to sedate the patient if the patient is feeling uncomfortable. And any intervention, if there is a complication, then intervening airway access will be much difficult in a prone position. So modification of prone is split leg prone position, and a prone flexed position for maximizing the surgical exposure. And next comes the lateral position, which is the second best position for surgical access. So these are the lateral positions with a kidney bridge. And this is a supine position. Supine position is modified for both PCNL and for urethrostomy procedures. If they are done together, This is a modified Valdivia position. And the next is the Bart's position. So these are the positions which the patient undergoes surgical procedures in PCNL surgeries and ureteroscopic procedures. So now this summarizes the advantages and disadvantages of positions of PCNL. So here in prone positioning, our worry as an anesthesiologist, we are worried about securing the airway. So airway access will be much difficult in cases of prone, and in lateral position also, it will be an suboptimal access. So now let's go on to the needle puncture. So in PCNL, so there are 3 points which we will have to know for the surgical access. The unknown point is determined, which is the target calyx where the eye of the needle has to be placed, and the 2 known points are where we enter and the point of skin puncture. So it can be either by ultrasound guided or fluoroscopy guided, or it can be a combined procedure. So now this is a review. Most of the articles which I quote are quoted by Sir also. So this is a review article on percutaneous nephrolithotomy, current clinical opinions in a neurology journal. So here they have classified the surgical complications according to Clivian's grading. So if you see here, our worry is mainly the pleural injury. So PCNL surgeries are more prone for pleural injuries, and we can think of it like the patient can present with pneumothorax, discomfort, fall in saturation, and in a prone position, it is very difficult for us to reposition the patient and intervene. And in cases of massive hemorrhages also, if we need to transfuse, and our primary mode will be airway breathing and circulation. To secure an airway, it will be very difficult for us. So now they have concluded it is safe to conduct the procedure under GA for complicated and prolonged procedures. And regional anesthesia is preferred only when the surgical team has a high degree of expertise and the procedures uncomplicated. I would like to reiterate this point that RA is preferred only when the surgical team has a high degree of expertise and the procedure is uncomplicated. A straightforward case we can do under regional. And we will not be able to, in regional anesthesia, we will not be able to control the spread, and we will not be able to have the, like if we need to reach a particular dermatome, we might not be able to reach. If it is a partial spinal, if it's a failed spinal, or if the procedure gets prolonged, and if the level recedes, then we will have to face some difficulties. So now, this is one case report which I found as a rare complication. This is an air embolism, which is a complication of percutaneous nephrolithotripsy. This is a 43-year-old female who underwent PCNL for a solitary calcial stone under general anesthesia. But this is an air embolism. This can happen in regional anesthesia also. So if it happens, then it will be a problem to us to tackle this. So now this is also a neurological journal, which is a meta-analysis where 9 studies are included and 5 full-text RCTs and 4 non-RCTs. They have also suggested, or they have concluded that RA is equally effective as GA. So that means GA is the standard of treatment, though RA is superior in postoperative pain relief and postoperative nausea vomiting. However, prolonged surgeries due to complex stones, skin infections, sepsis, fever would warrant GA. And the hitch here is careful selection of patients for regional anesthesia is a must. So it is our decision to choose if the patient will stand right for general anesthesia or regional anesthesia. If in doubt, we'll give the benefit of doubt to the patient and we'll go ahead with GA. There is no contraindication to general anesthesia in any surgery. Also, that stands for PCNL surgeries too. So now this is another meta-analysis. This sir had quoted. And here 14 studies are taken, 8 randomized control trials and 6 non-randomized control trials. Here, patients who underwent regional anesthesia have higher risk of hypotension, blood transfusion, and lower risk of postoperative fever and nausea vomiting. So here, the problem they have faced or they have quoted is patient's inability to maintain stillness during the needle puncture, difficulty in maintaining the prone position for a prolonged period, and if the patient is anxious, the patient tends to hyperventilate, and needle insertion will be difficult. And if at all, the patient is not very cooperative, then there is a chance of pleural puncture also. So conversion from GA, as we all know, conversion to GA in difficulty or complications have to be thought of. So now this is another article where there is a 3 years experience in a reference hospital, urological hospital. So they have documented the use of GA in PCNL procedures in 521 patients over a period of 3 years. So they have evaluated the surgery-related complications and also anesthesia-related complications. So they have concluded that GA is a standard anesthetic procedure followed, and RA can be a choice of anesthesia in selected patients depending upon the condition of the patient. So here they have faced the anesthetic problems as difficult intubation, laryngospasm, bronchospasm, refractory nausea, ischemic changes, and delirium. So another point to think is thermoregulation and visceral injury too. So in thermoregulation, this is altered by both spinal, regional, and general anesthesia. However, added on to the anesthetic procedures, there is a large volume of irrigation fluid and there is an alteration on the core body temperature. But in general anesthesia, there will not be any shivering. We will be able to control with muscle relaxants and all, which does not cause discomfort to the surgeon and as well as the patient. But in regional anesthesia, if the patient shivers, we will not be able to sedate or we will not be able to treat the shivering. Now coming on to the visceral injuries, the most common visceral injury is lung and the pleural injury, and followed by the hollow viscous perforation and also vascular injuries, because major vessels are in the vicinity and there is every possibility that we may injure the major vessels during the needling. So in supracostal puncture, patients should be cooperative and should follow the verbal commands and continue to breathe. If the patient is anxious, then we do not have control over the breathing of the patient. So GA provides protection of airway during prone positioning, and we can control the tidal volume during the procedure to prevent pleural injury, and most important thing, maintains the patient's and surgeon's comfort in prolonged procedures and in removal of large stones. So this is one study which compares spinal and general anesthesia for percutaneous nephrolithotomy, and as suggested by the sir, lower VAS and decreased consumption of opioids. I do agree with that. Postoperative shivering is higher with spinal anesthesia, and PONV is higher with general anesthesia. Both anesthetic techniques are safe and effective in PCNL. However, patient satisfaction scores and surgeon satisfaction scores are higher in GA, which is of prime importance. Now, on summarizing, GA is a standard practice, and GA offers advantage during times of complications, and patients and surgeon satisfactions are better with general anesthesia. Now, I leave it to the audience to choose according to your comfort and your patient's safety also. Thank you.